This is Jerry Hesch, and this is part 4 of this fascinating case. And we're doing remodeling here, so I don't have my x-ray viewing box available. So these are sitting against a window, unfortunately. Okay, so this is not a perfect angle. It's called an AP of the pelvis because it shows the entire pelvis. But the image was not taken perpendicular to the pelvic joint to the best of my knowledge. Now, I measure at least 7 millimeters of width, yes, at that portion. Normative width of the pubic joint is 2 to 4 millimeters. This client has not had any children. So we can't blame the birth process for causing her to have a wider pubic joint. Here's another film, and these images were taken in 2005 and 2006. So she's contemplating getting a more current image, and so here's one more. Now this one's difficult. That's the pubic joint right there, but I can't really trust it completely because of the angle, and behind that is the sacrum, and below that is the coccygeal joint right there. So there could be a little bit of misinformation, okay? Now, here is an image of the sacroiliac joints. Let's see if I can change the focus here. Okay, let's see if that'll settle down. Well, you can see my neighbor's roof. Let me move the image down. So there are her SI joints, and it begs the question of, is this wider? And it's debatable. It's a possibility. I would trust a transverse image such as an MRI or a CT scan, but that's that. You can have a significant increase in width of the pubic joint without a significant increase in width of the SI joint. So you'll see in the literature, you'll see images of a pubic symphysis that traumatically has increased to 25 millimeters wide, and then you look at the SI joints and they're measuring on the order of 3 to 4 millimeters, whereas normal joint width is 2 millimeters. And these are just simply two very, very different joints. So this is the third day that I work with this client, and she's a 35-ish female. And she always wakes up in the middle of the night and feels like her SI has moved and become stuck. And language is problematic, but I'm not here to discuss language. Something causes her pain in the region of her SI, and it feels to her like something is shifted and something's being pinched, and that's a valid construct. What I found today was that walking across the pubic joint, the face of both pubic joints is symmetrical, and same with walking across the top. Look, however, when I go across, when I palpate the fibrocartilage, the entire fibrocartilage is deeper than the two pubic bones, and to what I'll call a significant degree, based on comparing her to other people with similar body type, similar age, similar gender, etc., etc. Is that her norm or is it not? Well, one way of testing that is that I could test mobility from the underside through the ischia. So if I come on the flat part of the ischium, which is basically the lower third of the pelvis, and impart a posterior to anterior orthopedic stress test, I first have to take up any movement that's readily available. Right now I'm pushing with about 15 pounds of force. And now when I thrust it, it gives a little bit. I can see the heels move, but it's significantly less than what I would expect in someone with a hypermobile pubic joint, and considerably less than I would expect on a similar client, again with same gender, same age, and very similar body type. And this is present on both sides. So the same drill, when I take up all available slack and then I attempt to spring it, again I see your heel move a couple millimeters, when in fact the heel should move considerably more than that. So this affirms the possibility that the fibrocartilage is shifted posteriorly, and it's forcing the pelvic bones to wedge at the pubic joint. So another way to demonstrate that is to test transverse plane mobility of the hemipelvis, of each ilium. She looks very similar to a person who would present with a pattern that we name posterior glide of the sacrum, in which the sacrum is very prominent. And in fact, if we cross from her PSIS onto the sacrum, we actually climb up, okay? So she looks like that population of people in which the SI joint is completely blocked, completely void of mobility per this manner of testing, per orthopedic stress test. However, her sacrum has some mobility, okay? And her ilia have mobility when we spring them. Now some of the mobility, of course, happens outside of the SI joint, outside the pubic joint. I get that, and again, I'm not here to discuss that at length. But you can have an external restrictor of pelvic mobility, okay? I'm going to test transverse plane mobility now. So I isolate the PSIS, okay, and I'm springing at approximately a 45-degree angle, and I cannot even take up the slack in that direction. If I do the same thing on the right, I can't even take up the slack. So she's restricted on both sides, which we name, the name for that is a type 1 inflare. It's different than the osteopathic description. But if the fibrocartilage moves posteriorly, then it basically opens up some space in that anterior joint such that the pubic joint then can in fact compress. As a matter of fact, it has to, unless it's crazily unstable. So everything we're finding is congruent, but the proof is in the pudding. If I can treat her and improve mobility on each ischia and improve this mobility on each ilium, and palpate the pubic joint and find that that fibrocartilage there's no longer a divot, then I think that qualifies as best we can do in the clinic as demonstrating a distinct change in this joint. So this is a very interesting case because you don't often see people who have true hypermobility in the pubic joint and in the SI joint. A lot of people think that asymmetry causes hypermobility and such, and there's a lot of research to counter that belief. But here we have X-ray evidence that meets the definition of pubic joint dysfunction, or comes very close. Pubic joint dysfunction is anywhere up to an increase in the pubic width beyond the norm of 2 to 4 millimeters, and she's at more than 7. And after 10 millimeters, then it moves it into the definition of symphyseal diastasis, which is rupture with separation. So I'm going to stop my gab fest here. We're approaching 10 minutes, and I appreciate that much of this will be more meaningful to a clinician who has studied the basic and the advanced Hesch method approach to the pelvic region, but it's hopefully has some value for everybody. So we'll stop filming now. I'm going to treat it and see if we can improve on what we found.